evening, everybody. We're doing a session on good record keeping tonight. If you bear with me, I'll share my screen. I am happy for you to ask questions at any point and interrupt me. We're not a massive group, so that's absolutely fine. But, I'm absolutely fine as well if you just want me to talk you through everything. Like I said, there will be the Q&A later on. So, that's whatever you want to do, however you want to do it is absolutely fine with me. Okay, so we'll start off the session. So good record keeping is just one of the things that we are extremely passionate about. We know that it's almost one of the most useful tools that you have in the future to potentially defend yourself against accusations. And of course, it's also very, very important, and it's an ethical requirement from the GMC to keep good records. Okay. It's very important as well to kind of think about this. Like, we've had cases where a patient would make a complaint against the doctor to the GMC. The GMC will open an investigation, look into it, go back to the patient and say, no, this has got nothing to do with fitness to practice. You don't have a case, anything like that. But they can still issue the doctor with a warning for poor record keeping. They take it extremely seriously. Okay, so that is why we will teach this as many times as you like us to as well. So today's session, objectives, we're going to talk about the different functions of records. We're going to talk about how it is important in the area of multiple jeopardy. We're going to go over the GMC guidance on note keeping because it's really important you stick to that. And then we're going to look at what exactly is good records and how you can improve on that as well. Okay. So the first question, of course, is why do we keep records? And it seems like a really simple question. You think you know the answer until you start looking at all the different ways in which you actually use records. There's many more than you might first imagine. You have, of course, your primary reason for keeping records. It's a way that you communicate with other doctors. It's a way that you record the treatment that you've given to patients. It helps you remember what you've done and what you haven't done, of course. Notes are very, very important and really, really important when it comes to handover as well. Okay, so that's your primary function, and that's the one that you guys kind of obviously will get to do with day to day. But there is a secondary function, and it's not really any less important. And the first is, of course, that it gets used in audit ways. So when hospitals have to kind of find out what the demographic of their patients are in order to order medicines or allocate resources, clinical records is one of the ways that they do that. So that's why you so often will have these very, what seems like rigid and sometimes redundant forms. They all have a very, very specific reason, and they get used in these audit purposes. And also, of course, the one that we are most concerned with is it provides you with your medical legal protection. If you have a case where you have a patient saying one thing and a doctor saying another, more often than not, the judge or the jury, they will go with what the patient says from memory. And the reason for that is that for the patient, that particular incident was a one-off and potentially traumatic experience. Their memory of it is much more likely to be more accurate. Where with a doctor sees possibly hundreds, thousands of patients throughout a year. So, to say that the doctor remembers purely that specific thing that clearly, that is less easy to prove. So if you don't have records, it's really, really hard. You can use different things. You can say, well, normally a doctor would do this and normally a doctor would do that. But if you don't have it on the records, it's almost as good as saying, no, you have to admit that it may not have happened. Okay, so very, very important in that sense. The second thing when it comes to the medical legal aspect of things is, that we said it helps you remember. And the thing to remember about claims, they can often arrive many, many years after an incident. Okay, a patient has 3 years from either the date of knowledge of an incident or the date of the incident to bring a claim against either the hospital or the doctor. Now, if the patient was a child at the time of this happening, or so forth, then they have 3 years from their 18th birthday to bring a claim on their own behalf. Okay, so here you could potentially have something happening to a child when they're 5 years old. However, they don't bring the claim against the doctor until they're 20 years old. Okay, so it's a really long, long time to think that you may remember what exactly happened, potentially 10, 15 years ago. All right. When it comes to patients who have a severe mental impairment, there is absolutely no time limit. We have cases right now which sometimes, depending on the situation of the patient, sometimes the case will go active for a while, and then if the patient doesn't have the capacity to continue, the case goes on hold a bit. And then when the patient's in a better place, it goes active again. So, we have a few of those cases which have been going on for a long, 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 long time as well. Okay. There's also the case where you can have, because the date of incident could be many, many years, the date of knowledge can be many years after the date of incident. That also means that you could potentially have claims brought against a doctor's estate. So the doctor may, have retired or potentially even died, and this claim comes out of the woodwork that many years later. We've also got a couple of those. So it is extremely important that there's notes to kind of be able to defend the case, work the case, all of those type of things as well. Okay. Sometimes notes are all you have. So it is very, very important. This is multiple jeopardy, and what's very important, and you'll hear us over the years, you'll hear us talk about multiple jeopardy because it's quite unique to the medical profession, so it's important to know how things can potentially escalate. With a clinical incident, you can have a single thing happen in a hospital, and out of that, there can be a whole range of interested parties, interested follow-on investigations and stuff that comes out of this one clinical incident. For the most part, they're all in the public's interest. So any of the information uncovered during these investigations or hearings, any of the statements provided or evidence submitted in these different places, they all become public knowledge. So you could, for example, write a statement to the hospital because there's been a complaint at the hospital, and that statement could very well be used at a GMC investigation or even a criminal investigation, if that's the case. Okay, so that's the first thing that's really important. Number one, whatever information becomes to light becomes public and can be used in different kind of investigations. And number two, you can have this one incident and you could have 5 different investigations going on at any given time. So you could potentially be found innocent of having committed a crime, but guilty of being fit to practice. So just because you're innocent of one doesn't mean you're going to be innocent of the rest. So they're all very, very important. And whenever you put notes or statements in, we definitely want to look over those things on your behalf. Okay, right. Scary stuff over. Let's talk about records. So what are records? Of course, records are not a single document, and that's the most important thing to remember. When you are in hospital and you do your clinical notes in a particular way, and hospitals are different and GP practices are different and all the rest, it's very important to remember that anything that has to do with a patient's clinical care is considered to be a clinical record. It doesn't have to be written down. Clinical records can be phone calls or transcriptions of phone calls. It could be potentially social media messages that for whatever reason came in that avenue. So what's very important for doctors and medical students to remember is that, if information comes your way in a non-standard way, you have to make sure that that information is included in somewhere else as well. Okay, so if you take a phone call and that phone call gives you information, make sure, unless that phone call is going to be recorded and transcribed and added to, the clinical records automatically, you need to make sure that you reference the information from that phone call in your handwritten notes as well. Okay, especially if that phone call makes you change your diagnoses or influence the way in influence the order in which you're going to be treating your patient and things like that. Okay. The second thing really important is with all of this stuff is you have to remember that clinical records are disclosable under data protection. So you have to treat them with respect and handle them not just professionally, but securely. All right. You will, when you start working and stuff, you'll go through induction and they'll tell you about the data protection laws and all that kind of stuff. It is really important that you stick to them and you stick to the rules of your organization. Those rules are put into place to protect the data. If you lose a list or, which, we've seen cases like that, doctors leaving a list on a bus or in a Costa or under a mattress after they've moved out, if they forgot to shred it, things like that. If you lose a list like that, it's really important you speak up very quick, tell people that you've lost it so that the hospital can take action to limit the potential damage. Okay, you're going to get into trouble either way. It's much better that you get into trouble in a way that you were professional, you dealt with the issue, you're a learner, they're going to allow for that. What they will definitely not allow for is somebody being dishonest. Okay, extremely important. So, brings us to our first case. Okay, so you're an FY2, imagine now, and you attend a post-take ward round with a consultant following your on-night call. You are writing the notes. You see a 32-year-old female with severe asthma. She's quite short of breath. The consultant listens to her chest, noting an equal air entry and a widespread wheeze. She suggests nebulizers and to review. You leave the ward round briefly to answer your bleep and return, and you document asthma, nebulize, and review. An hour later, unfortunately, the patient collapses and cannot be resuscitated. The postmortem shows a pneumothorax. The consultant is confident that there is no evidence of that when she saw her, but when she goes and has a look at your notes, it's not very comprehensive. Okay, so really important things to kind of think about when you do this kind of thing is if you are a consultant, right? Number one, you are supposed to be able to trust the FY2s, the FY1s to take your notes for you. But ultimately, of course, the responsibility lies with the consultant. So the consultant should regularly review these notes and check, especially when it's, contentious things or very, very important information as well. Okay, there will be differences in what a consultant expects from you your first few weeks as an F1, and of course what they're going to expect of you after they've worked with you for 6 months. Okay, if you do leave the room, it's extremely important that you go and check your bleep. Okay, it's very important that you then leave the note-taking responsibilities to somebody who stays behind. You definitely can't record something that you didn't actually witness. All right, so very important. If you do have to leave the room, make sure that you transfer the responsibility, or if for whatever reason you were the only one you couldn't, check with your consultant and say, this is what I wrote down. Did I record everything you wanted? Okay, that is extremely important. You can't just always lie on the consultant's shoulders. You do want to be able to be helpful to them as well. Okay. Now, lastly, this particular thing is just to kind of show you how multiple jeopardy got involved in this case. It's ended up with, obviously, it went to the coroner, so there was a coroner's inquest for this complaint. For this patient. The patient's family complained to the hospital. They actually weren't happy with the hospital's reply on this complaint, and they escalated it to the ombudsman. And they also referred the doctor to the GMC for investigation as well. Okay, so a lot of different things that can come out of it. Right, next case. This patient, and those were the notes that was there at the time. This patient died 3 days later after this exam, died 3 days later from a PE. Okay. So this is the notes that was available that the doctor made at the time. And I'm going to show you what we would rather have wanted to see. I'll give you a chance to read through that. Okay, so hopefully, as you can see, it tells a much more comprehensive story of exactly what was going on. Okay, it's very important to record significant negatives, of course, as well. And really the question that when it comes to notes is, sometimes things happen to patients. I mean, it's not about whether or not you could have prevented anything. The question is, if you were the doctor that was going to be asked, and you had to say, can we see your notes? What kind of notes would you rather at this stage be able to give them? Okay, so it's very, very important to not get into bad habits, not to cut corners when it comes to notes. Okay, a lot of abbreviations there as well, and we'll talk about abbreviations in a little bit as well. Okay, right. Now, coming on to the GMC guidance on note keeping, you have your good medical practice that you're going to be learning through school, and that's absolutely great. But the GMC website also have loads of information on good record keeping. They have loads of different advice booklets, and note keeping tends to kind of be a very prominent part of most advice as well. Okay, when you read GMC guidance, because it's a good place to start if you ever have a conundrum or if you have a query and stuff like that. When you read GMC guidance, what you're looking for, because they write it very, very clearly. They tell you what you must do and what you should do. Okay. Now, obviously, the things that you must do, if you don't do those things, you will get into trouble. The things that you should do everything in your power to be able to do those things. But if you can't, you have to give them a reason as well. All right, so it's not just enough to say, oh, it was only a should. You can't. It didn't say that I had to do it. The idea is that you do try your best to make sure you do those things as well. Okay, so from records here, it says clearly, documents you make to formally record your work must be clear, accurate, and legible. Okay? Poor handwriting is something that's actually in your control, and you have to do something about it. Okay, it must be legible. You should make records at the same time as events or as soon as possible afterwards. So here they kind of allow for the fact that it might not physically be possible for you to make them, straight after the event, but you should try your absolute best to do it as quickly as possible afterwards. All right. You must keep records that contain personal information about patients, colleagues, or others securely and in line with any data protection requirements. Okay, so for you guys, very much from now all the way through your life, if you're ever compiling data or lists or contact details, if you're going to put on a course or create a group or anything like that, if you have people's data, you have to look after it securely. All right, cool. Then lastly, when it says about what clinical records should include, relevant clinical findings, decisions made and actions agreed, and who is making those decisions and agreeing those actions, the information that you give to patients, and that can include leaflets and things like that, any drugs prescribed, of course, or other investigations or treatments going on, and then very, very importantly, who is making the record and when. Okay, I'm going to touch on that point a little bit later as well. First, we're going to go to medical acronyms. Now, normally, in the good old days, if I had you in a lecture theatre, I would make a game out of this and throw chocolates at you, but we don't have that opportunity right now. So I thought, just to lighten things a bit, these are abbreviations we have come across in records, some older records, some not that old. So old, you'll be a little bit surprised. But I wonder if you can, let me just see if I can see the chat. If anybody wants to have a guess, let me just open the chat. If anybody wants to have a guess what OAP in this context stand for, and I'll give you a hint, it's not old age pensioner. So I'm not getting any answers, so I am going to assume that you guys don't fancy interacting tonight. And that's absolutely fine, but that means I'm going to open access plus. No. Over anxious patient was this one. Okay. What about FLK? Anybody want to have a guess at that one? FLK? I'm going to go on because I think that's fine. But yeah, so is it to do with pediatrics? It's to do with kids. Funny looking kid, that one. I know. And these are real ones that we've pulled out of records. You know, we're not making this stuff up. Normal for Basildon. Saying that, I have seen normal for Norfolk before. Normal for Basildon is a little bit more regular at one point. And I have also seen one called NW3 Plus. I think it was referring to posh people or something. We have God Only Knows. Acute thespian syndrome. Same as last time. And unexplained beer injury. Okay, so obviously you'll agree with me that these are not to be used. But like I say, we've pulled them out of real records. The next one, I'll let you have a quick look at that and then I'll tell you the story about this one. Okay, this one's a few years old, but it's a good story because it just kind of proves a very important point. So the lady went to see her consultant. He examined her. He wrote this note and said to her, I want you to have a consultation with my colleague down the hall. He wrote the note, he put it in her file, and he gave her the paper file so that she could go and sit in the hallway outside this other consultant's office so he could quickly see her. Of course, while she was there, as any human would, she opened the file and she saw this note and she left. She left the hospital. She left the hospital. She left the folder on the chair. And she went straight to the police to make a complaint. Okay. Now, in this day and age, unfortunately, the chances are that a patient like this who has this kind of query and this kind of complaint could unfortunately very easily go to the press. And once things get out in the press and social media and all of that, it's very, very hard to control. The doctor, as you can imagine, can go through so much. It can ruin their reputation long before they get the opportunity to explain that it says, could you kindly see the above? Okay, so it is extremely important, the handwriting thing. We can't preach about it enough. Okay, right. So in a nutshell, of course, quality records, there we go, needs to be legible, it needs to have a date and time, and it needs to be signed. Now, when we say it needs to be signed, we are not saying that we want you to do a scribbled little signature, okay? When you sign records, it needs to be legible. So when you sign them, you need to you can do a signature if you want, but you need to also print your name, okay? It's important that people know who made that record and when, if you remember with the GMC guidance before, who made the record and when. And a scribbled little signature is not how you tell people who made that record. Yeah, you may be very well known in a particular ward or something for a while and people can read your writing and they know that's you. That's not going to be helpful 20 years down the line, is it? So, and it's definitely not going to be helpful when you move to a new department with new people who don't know these things. So very, very importantly, when it comes to date, time, and sign. Now, A lot of hospitals these days will give you stamps when you start working for them, and it's definitely something you should always try and use. It's clear, it's legible, it follows the rules. All right. Also, of course, only use approved abbreviations when you do make these records. Now, we do give an attendance certificate for anybody who joined here tonight, and I'll give you the QR code for that a little bit later on. And with that attendance certificate, I will send you a list of approved abbreviations as well. Okay. You can find it in different places. I just think it's really good to have. So I will send you a copy of that as well. Okay, right. So what does the quality records, what content should they have? Of course, it needs to have a patient history. Very importantly, though, we suggest you make sure that when patients give you descriptions, like, for example, this one, pain is like a vice on my chest, it's very helpful to use their words. Okay, and number one is because it gives an accurate idea of exactly what they said. You're not just interpreting what they said. And secondly, if, for example, years down the line, they're reading their notes for whatever reason, it's much more likely that they will recognize, like, oh yeah, I did say that, when it's written in their own words. Okay. If you use jargon and things like that, they're not going to necessarily agree that that is what they said and so forth. So it's very, very useful in that sense. It's really important to remember to note both positive and negative answers to questions, both positive and negative findings to investigations as well. And always remember to use objective measurements. Whenever you're writing these kind of notes, have it in the back of your mind that one day the patient might be reading these notes. So consider how you phrase things. Okay. Also, very important to include, of course, the differential diagnosis and the management plan. It's very important that with the management plan, you also keep notes on the progress that is made. And really, really importantly, if that management plan changes for whatever reason, okay, make sure to include the reason that that management plan has changed. All right. It could be something really simple, like, you decided to do this because there's too much of a queue there, so you're trying to be useful. That's absolutely fine. Make sure you say that that's the reason you did it as well. Okay. It just gives for a much more comprehensive picture as well. All right. So next, just a few fun things about, computer records. That's always kind of quite like these. Now, for the most part, mostly GP surgeries and some, I think there will always somewhere be a space for paper records. There's just some things that just lends itself better to a pen and paper. Obviously, ultimately, everybody wants to eventually be completely digital, but it has its own, can have its own problems going digital. We'll talk about those in a second as well. Mostly and very importantly, if you do ever use dictation, if you do ever, use computerized records, a lot of these systems now will disable things like autofill and so forth, and that's a really, really good thing. But we do find every now and then, especially when you have a GP surgery using something for the first time or they get a new system installed and stuff, sometimes the IT guys forget to fix the autofill. So this kind of thing can happen. Okay. Right. It's just maybe, check your stuff over before you submit or send it and things like that. Just always double check. So the advantages of computerized records, there are loads of different advantages. I've chosen the top 3 from a medical legal point of view. So for us, the really good things about computerized records is, of course, it's typed, so it's legible. It gives a really clear audit trail. It shows who accessed what, when, it makes you tick boxes before moving on, that kind of thing. That can be really, really useful. And of course, we really enjoy the fact that it has passwords and access levels. So you can imagine, a doctor or or the head of a department will have different access to a medical student who's on the ward only for a couple of days. And that's a really good thing. It means that, some things can be held securely, some things can, only be for certain eyes. With that in mind, it is extremely important that when you work on the wards and things like that, you never ever share your passwords. Okay, you never share your logins. I don't care if if the locum is there and he needs to work and he can't get onto his own system. You just can't do it, okay? Because at the end of the day, 10 years down the line, it's your name against those records. Okay, so please, you will, when you start your first job, you will go to your induction and you will sign a piece of paper that says, I won't share my login details. Okay, and then you may very well find in the first week there's some pressure for you to do that. Don't do it. It's the one thing that you definitely should not do. And you will not. You might get somebody being mean to you on the day about it, but they will never carry it any forward, and you will never actually be told off for following the rules. Okay, so just important to stand fast there. A few disadvantages, and again, I've kind of highlighted the three that, for us is the most that we see. You can sometimes, especially again, I'm thinking of GP land, when there's this trend where doctors because they're having to multitask and things like that, it's a little bit less at the moment with social distancing, but they're going through this trend of kind of having their screen in a way that the patients could see. So they could see what they're typing and things like that. And it is nice for patients to be able to see that stuff, but you also have to be really careful that people walking past your room can't also see it. So there is that kind of risk of breach of confidentiality. So you do have to be very, very careful with that. Or the fact that, potentially the patient didn't want the partner to see everything. And because it's facing them, suddenly there's information available. Okay, things like that. There's also, of course, humans will always be lazy. So there is the chance to, potentially click yes on messages when you haven't actually done the thing, things like that. There's also the potential of, if there's a lot of drugs that are the same, it can be easy to pick the wrong one off the list. So it's just really important you do double check. And then lastly, and this, I think is going to be one that's always going to be there, is kind of the effect a computer has on the dynamics of a consultation. And I know it's a bit of a mouthful, but when doctors kind of, try and work so hard and multitask and type away while they're talking to patients, sometimes patients can get the impression that they're not being listened to or they're not being given focus. So a good way to make sure that doesn't happen to your patient is to always make sure you give them a minute of your time without doing anything else before kind of starting and multitasking. Just focus on them, make sure they can, start telling you everything, and then you can kind of move on. You've given them that initial focus. Okay, it really, really helps with rapport as well. All right. Now, if you do find yourself in a situation where there's an IT system failure, we have had a few in the last 10 years or so, and they can really cause a lot of havoc in hospitals. Now, I would imagine if it happened to you guys, you will be pulled aside and there'll be somebody in charge and tell you exactly what they expect from you, what they want you to do. And that's absolutely fine. But we do ask that you do keep in mind and keep an open mind to make sure that what you're doing is right. Okay, what you're doing is making sense. What we do find sometimes, protocols and technology move on so quickly that protocols can get really out of date quite quick. So this might be the rules, but there's been recent changes and things like that. So maybe the rules are not the best way to do it anymore. If that is the case, just make sure that you speak up and bring that to somebody's attention, because it could very well be that the person giving direction for everybody just doesn't know how that new feature has been on the ground and things like that. So just do speak up. Make sure that you mention these things to people. It's all about keeping your patients safe. Okay, you will probably have to make handwritten notes. There will probably be more work when everything has to be put back into the systems or uploaded or scanned or whatever. If you don't have access to medical histories, make sure you retake them, take full ones. Make sure about those drug allergies. Okay, make it really obvious. Ask and ask again. Okay, if you can't be sure, it's really important to just keep asking those questions as well. All right. Dictated notes, I've kind of already touched on. It's just very important because we are finding a lot of students are enjoying taking dictated notes these days. There are great apps out there. It's just really important that you do know exactly, where this data is being stored and things like that. Be careful not to breach data protection laws. I mean, we have now left the EU, so there will be up-to-date guidance on, data traveling overseas and things like that. So it's just really important to kind of know that stuff. And very important to just check over your dictated notes as well. Definitely don't use unauthorized apps or packages for stuff talking about real patients. Okay, just double check, triple check to make sure that you're allowed to use it on there. You need to also make sure you have consent for all the right things as well. Okay. All right, so we're going to move on to, I'm just checking the time, we're good. Just going to move on to a case of missing records. FY2 attended a ward at night to review a patient with chest pain. While there, the nurse asked her to review another patient who had developed a painful foot. The FY2 saw the patient, prescribed some stuff, but was then bleeped to an emergency and forgot to write it in the notes. 2 years later, unfortunately, this doctor, who was at that point a GP trainee, got a letter from the trust solicitors saying that there was clinical negligence and that the doctor never touched the foot. Okay, so that's very, very unfortunate. This is a good example of where the doctor remembers one thing, but the notes, unfortunately, don't back it up. Okay, so there's many potential pitfalls when it comes to records. So, obviously on the evidence of this patient, even though, it was unlikely and all the rest, unfortunately, they have to go by evidence or by what they can prove. And in this case, the judge in the case decided that the patient must, had quite an accurate memory, everything else added up. And the NHS had to settle this claim. Okay. Unfortunately, sometimes that is just the way that it has to go. If you can't prove it, then, you kind of have to settle it as well. All right. So missing test results. Your FY1, you're asked to review a 19-year-old patient on a day case unit who has had an elective hernia repair. Patient was due to come home but had felt nauseous and faint. After review, you asked the nurses to check some bloods and said that he can go home as long as his final blood count's normal. They contacted your colleague to call to confirm the normal blood count, and the patient was discharged because you'd already gone home. 4 days later, this patient was readmitted with DKA. The admitting doctor notices the glucose level you requested was raised. So, that's a little bit worrying. Of course, that's not a final blood count, a normal final blood count. So it seems that the result was phoned through to the ward and had been passed to the consultant to review, but the patient had already been discharged. Okay, so this one is what they almost call a series of unfortunate events, of course. Things were delayed, wrong information was passed over. There's a lot that has gone around here, and it doesn't really fall just to one person. But this is a good example to show how important those handovers are, to be exactly clear about what needs to be done and what should definitely be checked. And if you're the one who's following instructions from somebody else, just because the discharge instructions is there, you still have to really make sure that those are still relevant for your patient at the time that you're dealing with them as well. Okay. Handovers is just one of those key areas where mistakes happen. So this is why you will probably find that you regularly get training on how to do those and what to look for as well. Okay. Next case, moving away from some clinicals. Here's a good one about data loss. So at the end of this shift, the FON decided to clear out her locker. And she had a number of post-take ward-round job sheets which needed to be shredded. They had stickers on them with lists of diagnoses and outstanding investigations, and she was going to go shred them in the secretary's office, but she bumped into a colleague on her way there and she got sidetracked to go for a coffee. Okay, unfortunately, the papers fell out of her pocket and somebody picked them up and handed them into hospital reception. This doctor, unfortunately, had it where the trust took disciplinary action for the loss of confidential data and the failure of her to declare that loss. Okay, so this is really, really important as well. Now, for most parts, as I said, you will get into trouble for losing things, and that is fine. And usually, especially while you're in F1, while you're training and stuff, it'll be seen as a learning experience. So they will say to you, in the future, do things this way, in the future, do things that way. The problem is when you don't own up to it. Now, there's two things. This particular doctor knew that she had lost the papers, but she decided not to tell anyone. And that is why she got into a lot more trouble. If she had simply told them, they would probably have not done any of this. It's because she didn't tell them. She didn't own up to the fact that she lost the papers. Okay. There's always, of course, that they know this. The doctor went looking for the papers. She asked a couple of colleagues if they'd seen the papers and all of that stuff, but she didn't actually then go and declare to anybody that she didn't find them. Okay, so that is really, really important. You'll get into a lot more trouble for not owning up to things or being dishonest than you would for making a mistake. All right, okay. Just to kind of talk about Data Protection Act, of course, and as I said, there will probably be some changes. I don't think the changes since GDPR came in. So this is where we're all having to accept cookies, and we get so many different emails telling us that we're still on the database. Do we still want to be on the database? This is all because of something called GDPR. And even though we've now left Brexit, we're probably still going to be following those rules anyway. Okay, so it is very important that you're careful with it. It's very important that you follow the data protection laws and the rules as well. So if you are going to, as I said before, do any courses, anything like that, you do, as a doctor, have an ethical responsibility to not just keep patients' details safe, to keep colleagues' details safe, not give out colleagues' information, things like that. We had a case not that long ago where a doctor was annoyed with a colleague, and he gave a patient the colleague's home number because he thought it would be funny for the patient to call the person and annoy him when he was off and things like that. So you really can get into so much trouble for doing that. Okay. Next one, let's look at a request for records, because this is also something that you may come across when you work in hospital. So this is where the daughter of an 83-year-old female patient, the patient had early stage dementia, and the daughter had complained about various aspects of her mother's care. The trust provided a response to the complaints, but she wanted to clarify some points, so she asked to see her mother's medical records. So what kind of stuff do you need to consider when it comes to disclosing records? Now, obviously in a hospital, there's usually a policy, and we will go over that in a second. It's really important to know whether or not, number one, just because the patient has early stage dementia doesn't mean that the patient is incapacitated. If the patient is incapacitated, we need to know whether or not the daughter has the right to have access to those records, or does somebody else have power of attorney? If the patient has capacity, does she give consent to the daughter accessing those records as well? Okay. So So normally in your scenario, you would refer this daughter straight to the records office of the hospital so they can kind of deal with it. But it is important to kind of know what the procedure is as well, because it could be that they, simply ask, oh, can I just quickly see that? Can I just quickly see that? So it may be, about how you handle the situation so it doesn't look like you're hiding anything either. So it's good to know what the rules are. It's good to know where the consent is and who has it. Because it may be a really simple things like, oh, I just want to see that picture. I just want to see that X-ray. It looks interesting. And if the patient consents, then you could very well just probably quickly show them rather than making them go and get a copy of all the clinical records from the records office. Okay, so there are levels. It kind of depends on exactly what they're asking and so forth. It's just really important to know that there are rules. So the clinical records policy, trusts have responsibilities to do these things quickly. They can also ask and charge for things like, they don't really print things out anymore. They'll put things either on disk, well, memory sticks these days, but there could be a charge for the memory stick. There could be a charge for the time, the admin charges and things like that. So the medical records policy should include things like applying for access, what to do with third-party requests, so things like from insurance companies and things like that, Bupa. Children under 16, what are the rules, any charges that the patient would have to pay, or the requestor would have to pay. What to do if there's a request to amend records, because patients have the right to request that. It's not always granted, but they have the right to request that something in their records are amended if they feel it's been recorded wrongly. And lastly, of course, all the security arrangements and stuff as well. So it's just very important when it comes to records to remember you have this data protection responsibility, and it's quite serious stuff as well. Okay, right. So we can end on this. Top tips, okay? There's many top tips. I can't remember if I thought I might have highlighted a few. The ones obviously that we care the most, and you definitely want you to kind of take home now and start using, is be legible. Okay, practice your handwriting if you have to. Take lessons and get better at handwriting if you have to. Always be professional. Avoid personal comments. Avoid jargon and abbreviations that shouldn't be there. Okay, and very importantly, if you're going to be consenting for procedures, remember to do it all the way through. Check your patient's understanding all the way through, especially when it comes to things like working with chaperones, or if you can't work with a chaperone, any kind of intimate examination. And that can include things like looking in people's eyes or ears. You're still within their space. So it is extremely important to always, get plenty of consent, keep talking to your patient, keep making sure that they are comfortable before you proceed further. Okay, right. So that is the QR code for your attendance certificate, if you'd like one. What I'm going to do is have a quick look at the Q&A and the chat. And if anybody wanted to ask any questions, please go ahead.
Thanks for watching. Don't forget to like and subscribe. If you're watching this on YouTube, head to our website to watch the next part. If you're already there, just mark this part as complete.